practices at Livingstone University Teaching Hospital, Department of Radiology in South Zambia. All right, over to you, Eston Nyemba. You can start your presentation.
Thank you so much, Christine, for the introduction. Today I'll be talking about neonatal neurosonography. As said earlier on, I take this topic so personal to me because of the numbers that we get from the World Health Organization. They are staggering numbers. It is estimated that approximately 300 neonates die every year as a result of these malformations. But first, I would like to thank my colleagues for all the encouragements and constructive criticisms. In particular, Mr. Chawinga Wezi, my colleague from the radiology department here in Livingstone, and my mentor and my friend, Mr. Mlenga Cuthbert. So, our learning objective for this presentation is as follows. Because there is advancements in technology, so we need to modernize ourselves with the current practices of ultrasound. Back then in the day, we only used to depend on grayscale. But right now, things have changed and there has been a lot of improvements. So we need to keep ourselves abreast with these ideas. Also, we need to update our protocols. After today's presentation, we will need to look at updating our protocols so that at least we are in line. As we are all aware, it depends with the hospital that you are at. That they are the ones that bring up certain protocols or the protocols that we use. So we'll see on how we can incorporate the things that we learn in our hospital protocols. And also we'll look at the modern approach to aid ultrasound using Doppler. And I can assure you today, I'm not going to talk about in-depth Doppler studies, because what we don't want to do is to turn a 10-minute exam into a full transcranial ultrasound, which will become maybe 30 minutes or more. That's not what we are going to do here. We are just going to go through, to peruse through on what we need to do during these Doppler studies. Then we are going to look at the common anomalies. And you forgive me here, I've only picked the common ones, in particular the ones that I've come across in my 7-year professional career. How is the outline looking like? Today we're going to do something a bit unusual on anatomy. We are going to do a brief overview of neurulation, because this is where the problems begin. If there is anything wrong, if anything happens, anything goes wrong during the process of neurulation, mostly that's where the fetal malformations start from. Then we'll go to the windows and the technique. When we look at windows, we'll just limit ourselves to the anterior fontanelle and the posterior fontanelle. These windows, I looked at them in my previous piece. So if you want to know more about the details of the windows and the in-depth look, you can go to Radiology Without Borders and see the previous presentation about neonatal neurosonography. Then we'll look at the anomalies. Then we'll look at screening with Doppler and the common pitfalls that we encounter during the presentation. Anatomy. So this is neurulation. Now the process of neurulation is the process of neurotubule formation. We'll start at day 18. At day 18, this layer here These are three layers. There is the ectoderm, the endoderm, sorry, the ectoderm, the mesoderm, and the endoderm. Now, by day 18, this layer here, the ectodermal germ layer, is in form of a disc. So when we cut here, this is in form of a disc there. So it has a caudal and a neural, a caudal and a cranial end. This diagram illustrates that. So there will be, this is the caudal and this is the neural end. So the nuchal cord, this one, will induce the thickening of the endoderm germ layer to form a plate. Now, by the third week, the edges of the neural plate will extend to form neural folds. These will extend such that they will try to touch each other. The neural groove, here the neural plate, this will now become a neural groove. And as they progress, they will touch each other. They will come in contact with each other. As soon as that happens, as soon as they become in contact with each other, a crest of cells called the neural crest cells will form. They will peel off from here after these two edges touch each other. They will peel off and then they will migrate throughout the body. After they migrate throughout the body, they will become the Schwann cells, the meninges, the endocardial cushions, the prolifilar cells, and the adrenal medulla. And now by the time the 23rd day is coming, it would have become like this. It's a hollow tube, but the cranial and the caudal neural pores, they communicate with each other. They haven't yet closed. By the 27th, the anterior neural pore will have closed. This will give rise to the forebrain or the prosencephalon, the midbrain or the mesencephalon, and the hindbrain or the rhomboencephalon. These will further subdivide into 5 secondary vesicles. The forebrain, the midbrain, and the hindbrain, these are the primary vesicles. The secondary vesicles will be the telencephalon, the diencephalon from the forebrain, the mesencephalon from the midbrain, the mesencephalon, and the malioencephalon from the hindbrain. These will give the adult derivatives of the cerebral hemispheres from the telencephalon, the lateral ventricle, again from the telencephalon. The diencephalon will give the optic nerve and the third ventricle. The mesencephalon will give rise to the cerebral aqueduct and the third ventricle. Then the metencephalon will give rise to the fourth ventricle, and then the malioencephalon will give rise to the pons, medulla, the brainstem. Fast forward to the mature brain. The mature brain has lobes. These lobes are named after the skull, the bones of the skull they lie deep to. There is the most cephalad part and the most cauded part of the brain. So The most cephalad part is known as the frontal lobe. The most cowded part is known as the occiput. The lateral is known as the temporal, which is ear, and the parietal lobes. The parietal lobe is separated by the central sulcus, which is here, from the frontal lobe. These two lobes are separated by the central sulcus. The lateral sulcus will separate the other remaining three lobes, namely the occiput, the temporal, the occiput, the temporal, and the temporal is here, and the frontal lobes. They'll be separated by this lateral sulcus. So what will you see on sonography? On sonography, you see something like this. This is the corpus callosum, especially when you are at midline in the sagittal plane. You'll see something like this. This is the corpus callosum. The corpus callosum, of course, you don't need to know what I'm going to say, but you just need to familiarize yourself with the parts of the corpus callosum. It has the genu, the rostrum, the body, and the splenium. When you look closely here, you will see these grooves. They are grooves which increase the surface area of the brain. And on ultrasound, these grooves, they are used to look at the brain maturation. If you are grading the brain, if they ask you to look at the brain maturation, you will be using these grooves called gyri and sulci. There is the cerebral vermis, the pons, and the medulla. That's a brief overview of the anatomy. The technique, again, I'm just going to do a brief overview. Usually we use a 7.5 to 8 megahertz curvilinear transducer. It has good depth because you need to see all the anatomy, the overlying structures, you need to see them. But if you need to see the pia, the dura, and any kinds of bleeds that you are suspecting, especially the extraaxial fluids, you would have to use the high-res transducer, specifically 11 to 12 megahertz. For premature babies, you have to use the phased array transducer because they have small fontanelles. So, technique. The patient, the neonate, you put the neonate on the back, preferably with the parents in the examination room. Then a sonographer will sit by the end of the bed, the edge of the bed, facing the head of the neonate. The transducer should point to the patient's, the transducer pointer should be at 90 degrees, pointing to the patient's front. Then if you want to get other images, you can just turn 90 degrees to the lateral side. Or preferably, this is my most preferred method. Since these babies move a lot, you just fold them into a blanket, lie them on the side in case there are secretions. Then, since again, with infection prevention, it's key with these babies. Remember, at my institution at least, when we are going to neonatal ICU, we put on shoe covers, then we clean our machines, we wash our hands. So if you want to extend your infection prevention, you will roll the cable around your arm so that it doesn't move around. So these are my preferred patient positioning. Of course, you can use your own patient positioning if you want. It also depends on what you use at your institution. So before now we dive in our topic, this is when it has started. We need to know a few principles of aid ultrasound. The principles of aid ultrasound are 3 that you need to familiarize with. You shouldn't forget all these. White matter should always look like white matter, and gray matter should always look like gray matter. If you see areas of white matter appearing to be gray, that's a problem. Normal is always asymmetric, but asymmetric are not always normal. This principle will help you, especially in ischemia of the thalamus, bilateral ischemia of the thalamus. It will help you. Remember, normal is always asymmetric, but is asymmetric doesn't always mean normal. And you should always visualize all the layers of the cortex, the pia, and the gray and white matter. The standard views are 5 coronal and 5 sagittal, the mastoid, and the posterior, including the temporal. These are just extension of views that you need to obtain or observe. So as the patient is lying, you get your transducer, point up facing the front of the patient. You need to see all these. It's a lot that you need to see on the mid-sagittal plane. You have to see the corpus callosum. You have to see the cavum septum. You have to see the massa intermedia. The 3rd ventricle should be somewhere there. Then you have to see the aqueduct, pons, and the medulla, and this is the cerebral venice. You need to see all these. So you are starting at the midline. Remember, where do you go next? You go lateral. When you go lateral, either right or left, you will see the thalami, the caudate nucleus, and this groove here is called the caudothalamic groove. This view is very important, especially in preterm babies where you expect to have bleeds. From there, you go lateral, further lateral until you see this view. This is the Sylvian fissure. This view is also known as the chandelier view. From there again, you go to the midline, and if you started left, you go midline and you go right. The coronal. After that, you turn your transducer 90 degrees to the patient's right or to the neonate's right. Then you push your transducer furthest in front. You will see these. You don't have to move. Where you are, you just slide, angle the transducer furthest to the right, to the front. You'll see these, the orbits. This should be your first cutting plane. When you see the orbits here, you see the frontal lobes and the interhemispheric fissure. You count 1. Remember, it's 5 coronal, 5 sagittal. So this is the first one in the coronal. The second one, you see the interhemispheric fissure, the cavum septum, the lateral ventricle, the Sylvian fissure. Excuse me. The Sylvian fissure. We've counted 2. The third one, You are coming back, remember, you had angled it most cephalad. Now you are coming back powdered. You see the lateral ventricles, the choroid plexus, the third ventricle, the temporal lobes, and the sylvian fissure. 4, you see the choroid plexus. Once you see the choroid plexus, you would know that you're at the level of the lateral ventricles and the periventricular white matter, which is white. Lastly, you look at the parietal lobe. Parietal lobe, the periventricular white matter, and the occipital lobe. Then you move to the posterior. If you want to look at the fourth ventricle, this is an auxiliary view. You move from where you were, you come to the posterior fontanelle. You see the fourth ventricle, the pons, and the cerebrum. So the cerebral vermis. Those are the few windows that you use. And if you want a comprehensive look at these, I previously did a piece on the same, just that then I was concentrating on preterm babies. The anomalies, again, you have to forgive me here. The anomalies, I've looked at the ones, I've included only the ones that I've seen. So we'll look at hydrocephalus, hypoxencephaly, corpus callosum agenesis, and Dandy-Walker malformations, and we'll end with vein of Galen malformations. Hydrocephalus. Hydrocephalus is defined as the fluid buildup, abnormal fluid buildup in the brain. There are 2 types. There is communicating hydrocephalus and non-communicating hydrocephalus. Communicating hydrocephalus is usually, you're born, a neonate is born with communicating hydrocephalus, or shortly after birth, it will be acquired. Then there is non-communicating hydrocephalus. Non-communicating hydrocephalus usually is as a result of the blockage. If we remind ourselves of how fluid flows in the brain, remember, it is cerebrospinal fluid is manufactured, it's made by the choroid plexus in the lateral ventricle. It's worth noticing that the choroid plexus is not only in the lateral ventricles, but a small portion of it is also found in the third and fourth ventricles. So, as it's produced by the choroid plexus in the lateral ventricle, it will move from the lateral ventricle to the third ventricle by the foramen of Monro, from the third ventricle to the fourth ventricle by the foramen of Sylvius of aqueduct, and from the fourth ventricle to the subarachnoid space, it will go via the foramen of Magendie, 1 in the middle, and foramen of Glushka. There are 2 on either sides. Hydrocephalus sonographically, when do you tell that this is hydrocephalus? Any ventricle that is dilated more than 1.5 centimeters or 15 millimeters, that's hydrocephalus. Some sonographers will use another method. I don't prefer this because it varies if the choroid is dangling too much. So it's 3 millimeters between the choroid plexus and the lateral ventricle, from here to there. If it's more than 3 millimeters, then you will know that this is definitely hydrocephalus. Again, on ultrasound, you see a dangling choroid plexus. So on ultrasound now, how do you differentiate communicating hydrocephalus from non-communicating hydrocephalus? Communicating hydrocephalus, you see all the ventricles communicating, hence its name, communicating. The third, the fourth, and the lateral ventricles, you see them all dilated. Non-communicating hydrocephalus, however, is a bit tricky. When you see the dilatation of the lateral ventricle, then most likely the obstruction is at the level of the Monroe, the aqueduct, the communication between the lateral ventricle and the third ventricle, the foramen of Monroe. Then, if you see the lateral ventricle and the third ventricles are communicating, then you know that it's much lower. It's at the aqueduct of Sylvius, and so on and so forth. That's how you differentiate this. How do you measure the ventricles? This is the anterior fontanelle that you're using. In A, this schematic diagram is at the anterior fontanelle. You measure parallel at the widest portion at the level of the atrium of the lateral ventricles. Again, if you want to get the perspective, the widest side, you go now to the posterior fontanelle. You measure at the widest portion where it's making a C. Then you measure including the choroid plexus. You use the, again, the anterior fontanelle with 1090 degrees, it will show you as a slit. It should not be more than 3 millimeters. This is how you measure the third ventricle. The fourth ventricle, you go to the posterior side. Again, not more than 10 millimeters. Then you measure across and along. That's how you measure. So if it's more than the lateral ventricle here, if it's more than 1.5, that's hydrocephalus. There, it's just showing how you measure. There. So if you look at this, this is A, B, C, and D. So A, B, C, and D. So this is A, B, C, D. I didn't put there. So I chose this picture deliberately to show you that this ventricle is dilated. This was 2.5 millimeters. This is a case. I know it has a little to do with what we are talking about, but this is a case I came across some 4 weeks ago in a neonatal ICU. This was a patient, and forgive my images here, they are a bit poor. I was surrounded, so I forgot to remove my camera, my flash on the camera. So this was a neonate that was diagnosed with communicating hydrocephalus. One of my mentors actually saw this patient. Now, this was a ventricular peritoneal shunt that they had put. You can see here it's labeled shunt. What was the role of sonography? The role of sonography was to see if really the shunt was failing or it was still in situ. What I observed when I did an abdominal scan, because there was abdominal distension, that was the indication. I found this cyst at the tip of the shunt. And when you look closer here, these bowels were floating. Even here, the bowels were floating. So the patient had a failed shunt. On the conclusion, we had written cerebral fluid in the peritoneum with a cyst at the tip of the shunt, indicative of a failed ventricular peritoneal shunt. I wanted to share this case because many are the times that these cases come to us and we really don't know what to talk about, what to do with the patient. Haloprosencephaly. This is a rare brain malformation that is characterized by the incomplete fusion or the separation of the incomplete separation of the two cerebral hemispheres. There are 3 types. Aloba, this is the most severe. Then there is semilobar, Then there is lobar. This is more friendly. These images are MRI images. I wanted to stress the point for us to see the differences. Sonographically, what do you see? You see a monoventricle. This is a monoventricle. The partially fused thalami. The Fowlkes line will be rudimentary, especially posteriorly. There will be absent cavum septum. There will be absent corpus callosum, and there will be a very vivid and very important feature that you should remain. It's called the snake under the skull. Because there is fusion of the thalami and absent corpus callosum, the anterior cerebral artery will course around and go underneath the skull. That will be the only way it can supply the rest of the brain. So this process, when you put this feature, when you put Doppler, you will notice it. This is what they call a snake under the skull sign. Even here, though it's not prominent. So those are the things that you need to see on sonography. One, fused frontal lobe, partially fused or completely fused thalami, rudimentary or absent Fowlkes, absent corpus callosum and cavum septum, and you have the SES coursing around the skull because of the fused brain mantle, known as the snake under the skull sign. Case study: this baby was brought to us after birth. He was born through cesarean section. The weight was about 5.1, if I remember correctly, 5.1. He had cleft lip and cleft palate. So the neurologist wanted to know if there were any extended malformations in the brain apart from the facial malformations that were able to pick on ultrasound. The ultrasound images, I only saved one. I started deliberately from CT images. I wanted to see the extent. Look at this ventricle. It's monoventricle, absent Fowlkes. Though the Fowlkes is, we can see here, it was rudimentary, partially formed. Look at that. The ventricles were huge. They were dilated. In fact, there was so much increased intracranial pressure that you can notice this bump which formed as a result of fluid buildup. This baby is very much alive up to now. This case came to me somewhere in January on the 7th. These are the features that we were talking about: monoventricle, partially fused thalami, and we didn't put color here. We obviously would have gotten the snake under the skull. The machine that we did, there was no color. Dandy-Walker malformation. Dandy-Walker malformation usually, it's defined as the presence of the cyst in the posterior fossa. I don't prefer that definition because it's not really a cyst. This results as a form of, if there is a failure in the foramen of Luschka and Majandi to open, which will cause the fourth ventricle to dilate. This is why you see this. So it's defined as the failure of the failure of the foramen of Luschka and Majandi to open, which will cause the fourth ventricle to dilate. So sonographically, you have to see the dilated fourth ventricle and or the cisterna magna, which is more than 10 millimeters. If you see a cisterna magna, which is approximately more than 10 millimeters, that's an abnormal. It's dilated. And if you see here, there is this vermis, there is aplasia of the vermis. So these are what you expect to see sonographically. This is an image, which is just the comparison of the two, how it will form. When you look at this image was taken way back when we were still crawling in advancement in technology in ultrasound and radiology at all. So when you compare the two, you see the aplasia of the cerebral vermis, which should be a prominent feature when you are talking about Dandy-Walker malformation. The fourth ventricle here hasn't dilated so much. Corpus callosum agenesis. This is the ill formation of the corpus callosum. If the corpus callosum is not formed well, the corpus callosum is formed between the 12th and the 20th weeks. So if it doesn't form, then you expect to have corpus callosum. That's definitely corpus callosum agenesis. This case was an unusual one, because what we are saying, why I say it's unusual, what we are saying on ultrasound, we need to see the lateral ventricles, the septum pellucidum should be absent, then the gyri should have what we call a sun ray appearance. This, when we were drawing the sun back in preschool, those rays, these, you need to have sun ray appearance. But this one, it is unusual because the lateral ventricles, they are not dilated and they haven't moved up. When you look at this, in fact, they look like they are absent. It was one case. Usually, it should look like this: dilated lateral ventricles. Of course, you won't be able to see as much of that when you get the sagittal, mid-sagittal view. So then the lateral ventricles, they will have what we call a bull's sign appearance, the horns of a bull. Instead of being close and well formed, they'll be small and they'll move up or down or lateral, straight. That's how they appear on this malformation. The vein of Galen. The vein of Galen malformation is an arteriovenous malformation. What does it mean? It means it's in the category where the high pressure arteries and the low pressure veins communicate directly. Usually how it's formed, the vein which was supposed to disappear and become a vein of Galen, which is a normal deep venous structure in the brain, will persist in life, and then it will feed these high pressure arteries. These babies, these neonates, they are usually associated with cardiac pathologies. The reason is simple. The heart will be pounding harder and harder so that it feeds this malformation. As a result, heart failure will come out. Sonographically, what are you going to see? An anechoic structure in the midline, posteriorly, and when you put color there, when you interrogate color there, you interrogate that anechoic structure. It will actually light like a Christmas tree. It will be like this. So any anechoic structure you see in the brain, be it a posterior fossa cyst, you need to put color there to rule out other malformations like the vein of Galen. We are done with the malformations. Doppler. What do you expect to see on Doppler. I said here I'm going to peruse through, because if I dive in Doppler again, it will be a wide topic. So you just get your midline. We'll see some images, some slides as we go down. The mid-sagittal plane, when you get the anterior cerebral artery, you put your waveform, your get there, your sample get there, then you trace the peak systolic and the end diastolic. After tracing that, you get these resistive indices. In premature babies, you get 0.8. In 10 babies, you should get 0.7 plus or minus 0.05. So these are the standard deviations, the 0.05. Then in a 1 year, it will be 0.6. In a 2 years, it's 0.5. Actually, since we are all equivalent to a 2-year-old, which is actually funny, every one of us, 2 years plus, it's 0.5, the resistive indices. This is what I was talking about. This is the mid-sagittal. You angle a bit, you see the basilar artery, then you see the SCA. SCA will divide into the pericallosal artery and the median callosal artery. You sample from there. The wave should look like this. So you pick, you go just calculate end, peak systolic, end diastolic, then you press enter, it will calculate for you. It will give you those previous resistive indices. That's just showing the mid-cerebral artery if you want to get it from the anterior fontanelle, coronal. When you see hydrocephalus, usually, this is where Doppler can be of help. You put your sample gate in the mid-cerebral artery, you will see forward flow and reverse flow if there is increased intracranial pressure. Forward flow in systole, back flow in diastole, then you know that there is increased intracranial pressure. However, if there is patent ductus arteriosus, if there is other malformations, again, like heart failure, when there is communication between the left and right ventricles, this won't work. So if the sonographer also puts too much pressure on the transducer, you get a view like this one. So very important to know that. So in fact, this was supposed to be SCA. I made a mistake here. So you go mid-sagittal, then you angle a bit. You see here, you sample from here. What are the pitfalls that we expect? Sometimes you can have a cyst magna which is dilated, but it's normal. We said more than 1 millimeter, it's problematic. But here it was 3 to 8. So these are the, in some cases, you find that 3 to 8 is normal. So this is another pitfall that you encounter. You find that you are measuring the cyst magna and it's 3.8, 3 to 8 millimeters, and it's normal. You may find a lateral ventricle which looks bigger than the other. This is very much normal in 40% of infants to have a lateral ventricle which looks dilated. So long as it's less than 10 millimeters in transverse, you are okay. You have rhampichoroid plexus or bulbous glomus. So long as, if this is the thalami, this is the caudate nucleus, so long as it's not anterior to this, don't say hemorrhage, geminomatrix hemorrhage, don't say that. So just say rhampichoroid plexus, but of course, sometimes it's a bleed and you have to point a bleed. That's why this slide was put on pitfalls. It's one of those gray areas that you encounter. Periventricular cysts, boring. These are periventricular cysts that will form in the white matter. So if you see a cyst in the white matter here, cystic cavitations, then you think of periventricular leukomalation. If you see it lateral to the lateral ventricles. It's a normal cyst. It's called neonatal cyst. And if you see it in the subependymal region, that's definitely a germinal matrix hemorrhage. Remember in the previous piece, I said get two views. So in the sagittal, you get this. And 3 rules of Edge Sono. One of them was white matter should be white and gray matter should be gray. But what is this? This looks white. If you go again in the coronal, you find that it disappears. So again, that's one of the pitfalls. Ventricular striatal, this one you notice it. Back then, we used to think, the scientist community used to think that it was associated with touch infections, chromosomal abnormalities, malformations, hypoxic states. But right now, we think that research has shown that it has no correlation to any developmental issues. One point that I need to stress out is if you see this in utero, then it's showing, it's highly indicative of ischemia. So these are the few things that I decided to share, and we haven't looked at them all. So ultrasound is still the first line of investigations that doctors order. The reason is simple, it's cheap and it's easy to access. So it has limitations. With babies, with small fontanelles, it's one of the biggest challenges. The movements of babies, it's another one big challenge. That's why that method is important. If you at least fold them in a blanket, then if sutures are closed, it will also be another big challenge. So this is not a perfect tool, but it answers clinical questions. It's more like we are peeping in a keyhole. In conclusion, I would like to say, with this age of radiation awareness, we need to know the best tools to use when we are investigating. So ultrasound technology has advanced greatly, and radiologists, radiographers, and sonographers must keep themselves abreast with new ideas, techniques, and other advancements that has happened in our profession. So these were my references. Thank you very much. I'm done.
Thank you very much for that detailed presentation. I'm sure we all picked up a lot of information pertaining to neonatal head anomalies. If there are any questions, this is the time to raise your hand and ask a question so that he can respond to some of the questions. All right. Does